Two talks, we covered cell injury and cellular adaptations. What happens to individual cells under stress? Today, we zoom out to the tissue level and talk about one of the most fundamental responses in all of biology, acute inflammation. This is the body's first responder system. It's fast, it's loud, and it's designed to do one thing: contain and eliminate whatever just threatened the tissue. By the end of this talk, you'll understand not just what inflammation is, but why it works the way it does, and what happens when it goes wrong. Dive into the mechanics. I want to establish something critical. Inflammation is not the enemy. It's easy to think of it as a problem because it causes pain, swelling, and tissue damage. But those are the side effects of a system doing exactly what it was designed to do. Inflammation evolved to keep organisms alive in a world full of pathogens and physical hazards. Animals that can't mount an adequate inflammatory response die from infections that would otherwise be trivial. The problem arises when inflammation is misdirected, excessive, or fails to resolve, and that's where disease comes from. What actually pulls the alarm? The immune system doesn't respond to injury randomly. It has sensors, sentinel cells sitting in every tissue. Primarily macrophages, mast cells, and dendritic cells carry surface receptors that recognize two broad categories of danger signals. PAMPs are molecular signatures from pathogens, things like bacterial lipopolysaccharide or viral RNA. Patterns that say something foreign is here. DAMPs are signals released by your own damaged or dying cells, molecules that are normally locked inside cells, and their presence outside the cell says, something is wrong here. When these sentinel cells detect either signal, they release a cascade of chemical mediators that launch the inflammatory response. It's an elegant alarm system. It doesn't need to recognize every specific pathogen. It just needs to recognize that something dangerous is present. The thing that happens after tissue recognizes danger is a rapid change in the local blood vessels. There's a very brief moment of vasoconstriction, almost reflexive, and then vasodilation kicks in. More blood rushes to the area. This is why inflamed tissue is red and warm. Rubor and calor, two of the classic cardinal signs. Then, almost simultaneously, the vessel walls become leaky. Endothelial cells retract slightly, creating gaps between them, and protein-rich fluid pours out of the bloodstream and into the tissue. That's edema. Tumor, the third cardinal sign. The five cardinal signs, rubor, calor, tumor, dolor, and functiolacia, aren't just descriptive trivia. Each one maps directly to a vascular or cellular mechanism. The immune cells need to get to the site of injury, but they can't just fall out of blood vessels randomly. There's a tightly choreographed four-step process. First, the neutrophils, the first responders of the immune system, move from the center of the bloodstream to the vessel wall. We call this margination. Then they start rolling along the endothelium, slowing down like a ball rolling along Velcro. This rolling is mediated by selectin molecules on both the neutrophil and the endothelial surface. Then a stronger adhesion molecules, integrins, interacting with ICAM1 on the endothelium, grabs them firmly in place. And finally, they squeeze between endothelial cells and follow a chemical gradient of chemokines that guides them to exactly where they're needed. This process is called diapedesis or transmigration. Every step as a potential pharmacological target, which is why drugs like steroids that disrupt adhesion molecule expression are such powerful anti-inflammatory agents. Neutrophils are the infantry of the immune system. They're fast, aggressive, and they show up in huge numbers. When you look at a tissue section from an acutely inflamed site, the thing you'll see most of is neutrophils. Those multi-lobed purple nuclei are unmistakable. They have four main weapons. Phagocytosis, they engulf pathogens and destroy them in internal compartments. Degranulation, they release prepackaged enzymes that can digest bacterial cell walls and destroy proteins. The oxidative burst, they generate reactive oxygen species, essentially a chemical flamethrower that kills bacteria through oxidative damage. And nets, neutrophil extracellular traps, a fascinating discovery where neutrophils literally eject their own chromatin as a web to physically trap pathogens. The catch is that all of these weapons also damage host tissue. A neutrophil doesn't have a precise aim. Collateral damage to surrounding tissue is inevitable, and in some diseases, like immune-mediated conditions, that collateral damage becomes the primary problem. The inflammatory response is orchestrated by dozens of chemical mediators. Think of them as the messaging system that coordinates every aspect of what happens. I want you to understand the categories and their logic rather than memorize every mediator. Histamine is preformed and ready to go. It's released within seconds by mast cells and produces that immediate vascular response. Prostaglandins and leukotrienes are synthesized from arachidonic acid. This is a pathway that NSAIDs block, which is why NSAIDs reduce pain, fever, and swelling. Cytokines like IL-1, TNF, and IL-6 are the long-range communication molecules. They travel systemically and cause fever, the acute phase response, and leukocyte activation throughout the body. Complement is a plasma cascade that opsonizes pathogens, tags them for destruction, and the complement fragment C5a is one of the most potent chemotactic signals in biology. When you understand what each category does, you can predict the effect of blocking any one of them. The blood vessels into inflamed tissue, the exudate, is itself a diagnostic clue. The more severe the injury or the more virulent the pathogen, the more complex and cellular the exudate. Serous exudate is the mildest, a thin, watery fluid like the fluid in an early blister. Fibrinous exudate contains large amounts of fibrin and signals serious injury. When you see the classic bread and butter appearance on a pericardium where both surfaces are roughened and stick together like buttered toast, that's fibrinous pericarditis. Supratif or purulent exudate is pus. It's packed with neutrophils and liquefied tissue debris. This is the classic bacterial infection pattern. Hemorrhagic exudate means there's significant vessel destruction, which happens with highly virulent pathogens or severe trauma. And pseudomembranous exudate involves surface necrosis overlaid with fibrin. You'll see this in some severe gastrointestinal infections. Learn to read the exudate. Acute inflammation doesn't always resolve neatly. The best case outcome is resolution. The cause is eliminated, the tissue wasn't badly damaged, and normal architecture is restored. This happens with mild bacterial infections, minor trauma, and most viral infections. If the damage was significant and the tissue can't fully regenerate, repair with fibrosis follows. We'll cover that in detail in Talk 5. If the cause isn't eliminated, say a foreign body is still present, or a pathogen evades the immune response, the acute inflammation transitions to chronic inflammation. If the neutrophils can clear the bacteria but can't drain the site, an abscess forms, a walled-off pocket of pus. And in the worst case, if containment fails entirely, bacteria enter the bloodstream, producing bacteremia and potentially sepsis, a life-threatening systemic inflammatory response. So, acute inflammation success or failure sets the stage for everything that follows. Key concepts from today. The two I want you to most hold on to are these. First, inflammation is protective, but it comes at a cost to host tissue. Second, every feature of the acute inflammatory response, the vascular changes, the cell types, the exudate, the mediators, is logically connected to the goals of containing, clearing, and staging repair. When you understand the goals, you can reason through any scenario rather than memorize it. In our next talk, we'll look at what happens when acute inflammation fails to resolve and the response becomes chronic, a fundamentally different biological process with very different cellular players. In this video, read the question and try your hand at it. We'll then go through the answer together. The thorn causes tissue injury, triggering damp release from damaged cells, and if bacteria are introduced, PAMP release as well. Sentinel mast cells in the paw tissue detect these signals and degranulate, releasing histamine. Histamine causes rapid vasodilation of local arterioles. The paw becomes hyperemic, which is why it's red and warm. Simultaneously, histamine and bradykinin increase vascular permeability, and protein-rich fluid leaks from capillaries into the tissue, causing swelling. Prostaglandins synthesized from the arachidonic acid pathway sensitize pain receptors, nociceptors, which is why the paw is painful. All four cardinal signs are accounted for with just a handful of mediators. Question, try your hand at it and we'll go through it together. A degenerate neutrophil has a swollen, pale, poorly defined nucleus. The nuclear lobes lose their crisp outline and take on a smudged, karyolytic appearance. This happens because bacterial toxins, particularly those from gram-negative bacteria, damage the neutrophil membrane and cause osmotic swelling. The presence of degenerate neutrophils on cytology is a strong indicator of a septic process. It tells you that a toxin-producing organism is present. Non-degenerate neutrophils with lobulated, dark, well-defined nuclei indicate a sterile inflammatory process, or that the bacteria present are less overtly toxigenic. So the morphology of the neutrophil itself gives you information about the nature of the infection. Pause the video, read the question, and try your hand at it. We'll then go through the answer together. This is a exudate, or more precisely, it classifies as serous effusion on the mild end. Low protein and low cell count tell us the vascular permeability hasn't changed significantly. Instead, this fluid is forming because of altered hydrostatic or oncotic pressure, not because of active inflammation. Classic causes in a cat would indicate right-sided heart failure, which increases hydrostatic pressure, or severe hypoproteinemia from liver disease, or protein-losing nephropathy, which reduces oncotic pressure, allowing fluid to shift into body cavities. Contrast this with a high-protein, high-cell exudate, which would tell us about active inflammatory vascular leakage. Reading the fluid is reading the mechanism.